So it's my privilege to introduce the next speaker because, number one, she doesn't need introduction. And number two, I'm not going to be reading a long bio. I don't make that same mistake twice on the same day. So it's my pleasure to introduce Dr. Sudha. She is the Anheuser-Busch Distinguished Professor in MIS, Innovation and Entrepreneurship. She also has a joint appointment with the Computer Science Department. Sudha came to the University of Arizona back in 1985. That's when she also got her PhD from the University of Illinois. And she worked on distributed databases back in 1985, even before the internet was invented by Al Gore or somebody else that I heard today. So she's always been at the frontier of discovering and creating new knowledge related to data and information. She has worked on distributed databases. She has worked on conceptual modeling. She has worked on semantic interoperability. And now she's really making a lot of progress and a lot of impact in data analytics. She and I co-founded Insight a couple of years ago. We're sponsoring this symposium. It's so exciting to have Sudha around in the department. Her middle name is Collaboration. She collaborates with everybody who wants to come and talk to her about data and data issues. She was a co-PI of a $60 million grant, the iPlant grant, the first instantiation of that grant. And she has this very long resume of funding, research funding, 200 publications, 200 articles. The PhD students who are there in the audience, that's what you have to shoot for. And it's just a pleasure to have her in the department. I interact with her every day. And so I just wanted to invite her to come and present on this exciting topic. Thank you, Sudha.
Thank you very much, Paulo, for that lovely introduction. So this is a very interesting project for us in Insight. We're working with partners in the healthcare industry. I would first like to credit my co-authors and workers in this project. A lot of the credit, as you know, doesn't really go to the professor. It goes to the doctoral students you work with. And so one of our doctoral students, Wenli Zhang, she also, by the way, doubles as a very good photographer. We wear multiple hats in Insight. We don't just work with big data, we also create the big data. So she's doing that with her pictures. Max Williams and Dr. Yolande Pengetens are from Parkland Center for Clinical Innovation. This project research is funded in part by the Parkland Center, and we're actually working with the Parkland Hospital in Dallas and other physicians in the emergency department that we've closely collaborated with along with their teams are Dr. Anand Shah and Dr. Ruben Amarasingam. So this project started off as a big data project. We started talking, Ruben and I started talking a few years ago about the emergence of big data. And then I served on an NIH committee with him on predictive analytics, on looking at the future of predictive analytics. And at that time we were talking about, well, what does big data really mean? So we said, well, let's get together, and you're doing a lot of work on big data. We're in the healthcare industry, and you're interested in it. Let's think about what we want to focus on. So this project actually uses asthma as an example, but it can be generalized to other kinds of chronic diseases as well as other healthcare challenges. Are there any asthma sufferers in this audience? Okay, lots of hands going up. This is actually a huge challenge in the US, 25 million people, causing 2 million emergency department visits, which are entirely preventable, and 500,000 hospitalizations resulting in a lot of preventable deaths. Also, $50 billion annually in medical costs in treatment. Of course, a lot of missed school days because childhood asthma is very prevalent, and missed work days. So we first started looking at chronic diseases, and if you look at a map of the US, well, you can see from the color, the dark brown is about pediatric asthma prevalence. And it is prevalent in a lot of states, especially in Texas and California. And so this was one of the reasons why we picked asthma, because this is a hospital in Dallas, this is a center in Dallas, and asthma is one of their biggest challenges. So our objective in this project was to develop robust models to predict asthma-related emergency department visits in near real time. And I think we're making very good progress, and I'll explain to you how we've done this. So there's a lot of asthma surveillance that happens. CDC issues weekly reports, but the problem is that there's lag time of several weeks. There's 3 to 4 weeks for hospitals to report their data to CDC, and then CDC aggregates them and reports them. So you really, you see the ups and downs of asthma cases, but you only see it after about 4 weeks. At the individual level, Parkland has worked on developing asthma predictive models using their electronic medical records, and more specifically, the history of individual patients. And what they've succeeded in doing is coming up with models that can predict who's going to show up in the emergency room within a 3-month time window. And so this is at the individual level. So at the population level, you have these reporting, surveillance. At the individual level, you have this prediction, but it has a very long time window. So our objective really was to see if we could do something in between. You know, our real goal is to go down to the personalized level, but we started with the population risk model, and we want to reduce the lag time for predicting how many people will show up in an emergency room to a day, for example, or to a few hours. So we thought, well, why not leverage big data? I've been doing a lot of work on big data in many different areas for a long time now. And to me, big data is not just about volume, and we've heard that message over and over again today. It's really about the variety, which is absolutely correct. So there's social media data. We're leveraging that in our project. We're leveraging internet searches through Google Trends. We're leveraging sensor-based data. You've heard the term Internet of Things. Well, there's a lot of different devices that constitute the Internet of Things, and one of them is the environmental sensors, which is very relevant for asthma. We also have wearable sensors, and we were starting to leverage those, but not in this talk. I'm sure there are a lot of people wearing something to track their number of steps they walked. Anybody wearing either the Jawbone or Nike Fuel or the Fitbit? Okay, well, so wearable sensors, we saw in the last talk and a couple of talks before that. We want to be able to leverage that. So variety is very important, but I want to go a bit further. What's really important for us is to learn how to leverage what's in this variety. And to me, the two things that are very important that we're leveraging in this project is when you look at these various sources of data, including your electronic health records, every piece of data that you track today comes with a spatial timestamp and a temporal, a spatial stamp and a temporal stamp, so a timestamp associated with it. And leveraging that geographic location and timestamp is actually what gives us the power to get insights out of data. So it's not just the variety, but it's the specific characteristics of the space stamp and the timestamp. And on top of that, a lot of this data is very fine-grained, both spatially and temporally. So you're not just getting city-wise or state-wise or country-wise aggregates over 3 months. What you're getting is individual down to the microsecond timestamp. So if you think about Twitter or sensor data, or even the wearable sensors, for example, you can actually get data down to the hour, the minute, the second. And to us, that's very important. So those are some of the characteristics we're leveraging. So on Twitter, I don't have to introduce this. I think Mark and Brian did a very nice introduction of how Twitter has locations. And so you can get locations in a variety of ways from Twitter data. You can get at the city level. You can even get GPS coordinates, or the lat-long coordinates, and the temporal. So for every tweet, you get a timestamp with a high level of accuracy. Google searches, of course, Google flu trends is very well known to people. You can actually get data from Google Trends, and you can use certain keywords just like you do in Twitter, and you can even specify the geographic area, although Google Trends APIs are not as finely grained in their resolution as Twitter is, for example, but you can still get data. So we were actually able to extract data from the area of interest during the time frame that we wanted to study. Environmental sensors, again, EPA has dozens, hundreds of thousands of data sets on various air quality variables. And you can actually, they have multiple sensors in different places all over the US, and you can actually leverage both the spatial and the location timestamp. So there's a lot of work that's been done using these types of data individually. So with Twitter, for example, the people have looked at Twitter messages to correlate them with CDC statistics. We saw some of that. People have used some machine learning techniques to extract and classify tweets, etc. We've also seen examples of Google flu trend. It's been in the news lately. There's also other work that's been done on all of these individual data sets. But what we really wanted to do was to combine, and so for us, big data was not just terabytes, but really combining these in a very novel way to see if we could then use it to predict visits to the emergency room. So we first started with de-identified data. So the reason why we're working with Parkland Hospital is because we needed the emergency room visit data. And like, I think it was Brian or Mark who pointed out that a lot of the CDC statistics that get posted are not at a hospital level. You have them at the city level, for example, very high level of aggregation. But we were fortunate to work with this hospital, and they actually gave us their ED visits for a whole year, and we took a subset of it for a period of time. And this period of time was a 3-month period between October and December, and since then we've extended the project. And you can see here on the x-axis is the time, the y-axis is the number of ED visits, and you can see an ebb and flow of ED visits for asthma as a primary diagnosis. And so we know where the hospital is located. We also know where the people for these ED visits are coming from. We have their precise zip codes, and so we're able to leverage that because then we can use that along with the locations from Twitter, Google Trends, as well as the environmental sensors. So we use the Twitter streaming API, and we collected 2 types of data. We used certain keywords to collect asthma-related tweets, and we call that the asthma stream. And then we collected a general Twitter stream, which is all of the tweets, regardless of what, whether they were asthma or something else, because when you combine data from multiple sources, or when you take a data set, you don't want to take absolute numbers. You want to normalize them so you can use them in prediction. So we have a general Twitter stream and an asthma Twitter stream. The asthma Twitter stream, we used, the physicians actually were very helpful in helping us identify common keywords that might be useful. So we had to go through a big process to decide on these keywords. So we used asthma, several misspellings of the word, terms for common medical devices associated with asthma, like a nebulizer, inhaler, etc. And the names of prescription drugs used to treat asthma, asthmatic conditions like albuterol, Singulair, and a few others. So these were some of the keywords we used, and we got a pretty good data set of tweets. In fact, if you look at it, In those tweets, we see other keywords as well related to asthma symptoms, runny nose, wheezing, sneezing, inhaler, etc. And this is sort of the trend of tweets. You see thousands of tweets. People, it's very interesting. When we started this project, I wasn't even sure that we could find anything about asthma on Twitter. What's interesting is when people have asthma, you would think they would reach for their inhaler first. No, they first tweet and then they reach for their inhaler, which is great for a researcher like me. I love that. Not so sure about the patient. This is kind of the asthma-related tweets globally, and you can see, and they're in various languages, but you can see obviously the English-speaking countries have a predominance. This is zooming in on the US. You can also see the various keywords. The orange is asthma, the yellow is inhaler, etc. And this is within the US, and I very quickly, I want to show you the, if this comes up really quickly, I can show you. So this is a real-time visualization as the data is streaming in over time, geographically and temporally. Okay. So you can see the timeline moving, and you can see the ebb and flow of tweets, and these are all asthma-related tweets. Okay, so I'm going to skip through this because I want to get back, and I'm afraid I'll run out of time. So we also have a similar one for US, and I can show you that. So what we did was, so as you can see from these various data sources, we have a timestamp, we have a geographic location. So we defined geo-boundaries for collecting the Twitter stream based on the ER-ED data set that we had. We know where the hospital is, we know where the people are coming from. So we drew a rectangle and collected asthma stream only from within that particular geo-bounded rectangle. And obviously, 80% of our time went in cleaning the data. As Brian said, actually it was probably more than that. Did a lot of things for cleaning the data. I don't want to go into too much detail. Also, I want to tell you that we only dealt with we removed all the non-English tweets because at this point, most of the people going to the hospital were English-speaking people. So it's interesting, you do want to extract signal out of all of this data, and there's a lot of noise. So on your left side, you will see people talking about, I had a mini asthma attack, I need to get to the doctor. On the right side, people talking about asthma attack because someone is taking their breath away. Obviously not every time I refresh my news page, I give myself, or first chemistry exam tomorrow, having an asthma attack. Those are really not relevant. I even saw tweets where someone actually went to a Justin Bieber concert and said, oh my God, I'm going to have an asthma attack, Justin Bieber, and I took a Snapchat or something like that. You do have to remove all of those tweets. So we actually used machine learning techniques to train a data set and then clean up, because we have so many tweets. We have hundreds of thousands of tweets, and you really cannot do it automatically. So we actually gave a sample of 4,500 tweets to 3 different ED physicians and had them classify the tweets. And God bless them, they actually did that. And we took that as the training sample, and then we used machine learning techniques to use that as training data, and we got a very good precision, and we were able to create a very clean data set. The next thing we did was we took Google search data. The interesting thing about Google Trends data is you can get data on a daily basis, and you can get it for a certain area. You can get it for that rectangle we were talking about. And so we used the same keywords that we used on Twitter to look at the total number of searches that were used to search on Google for those asthma-related keywords, the same 19 or 20 keywords. And we also went, and so we first collected the data set on one of the days where, in December, And then for some reason, we decided, well, we're going to go back and see how reliable the data is. So we did 2 more times, and it's interesting. The same keywords on Google Trends gives you 3 completely different data sets. And we weren't really able to explain, so I emailed Google, and I'm still waiting to hear from them about why there are 3 different data sets, and it's because the same keywords, but the number of searches are different. Then we looked at the AQI, the air quality index data, and I learned a lot about air quality. It turns out there are hundreds of different types of measurements on air quality. Who would have ever guessed? Because all we hear about is carbon monoxide and ozone layer, right? Well, there's PM 2.5, PM 10, there's nitrogen oxide. So all of my chemistry training actually came in very useful here. So we collected pollution data, again, from the same geographic region for the same time period. And we selected, so there's multiple air quality sensors, and sometimes you have sensors that sense every second, sometimes it's every hour, and sometimes you see gaps because the air quality sensors are down. So it's a very interesting process of trying to get this data triangulated and clean it up. So we got data on a number of pollutants, and you see these: carbon monoxide, sulfur monoxide, PM 2.5, et cetera. So we took this, and then we decided to first, so we also normalized all of our ED visits, because remember, what we're trying to predict is an outcome variable of how many people will show up in an emergency room. And so rather than predicting the actual number, we said we're going to predict high, medium, low. So we normalized it, and we used some rules for saying what's high, what's medium, what's low after consulting with the ED doctors. Our methodology is we're using a bunch of different machine learning AI techniques, and we also use some stacking and boosting techniques to see. But before we get into each of the predictions, what I wanted to say is so we have the Google Trends data, we have the tweets, we have the air quality index data on all those variables. We wanted to first kind of select a feature space to do the prediction. So we first wanted to run some correlations between the emergency room visits and the Twitter tweets, number of tweets, the emergency room visits individually with the air quality variables, et cetera. And so we found, much to our surprise and delight, that Twitter data there's a high level of correlation, very significant, between the asthma-related tweets and the ED visits, if you aggregate them at a daily level, and that's the level at which we did the analysis for this project. And so you can see very close correlation. So then we said, well, maybe Twitter data is correlated with everything else that goes on in the ED. So we decided to take something that was completely unrelated to asthma. In this case, it was abdominal pain, constipation-related ED visits, and we chose that because it affects a completely different organ system of the body. And so we found that obviously the Twitter data is not at all correlated, so that gives us evidence that Twitter would be a useful source of predictor variables for ED visits for asthma. Similarly, when we did the pollution data, we found that these 3 variables, carbon monoxide, nitrogen dioxide, and PM 2.5 levels, were most closely correlated. So that kind of brings down the number of variables that we want to use in our prediction. And so PM 2.10, interestingly enough, wasn't very closely correlated. Google Trends data, we tried. Remember, we had 3 data sets for Google Trends? Well, we tried this correlation with all 3 and found that 2 of them were not at all correlated. 1 of them had. But because we could never resolve this issue, why the numbers were different, we decided not to use Google Trends data. And then, so now is the results. So this is our input. So the outcome variable is the number of people, high, medium, low. And the inputs are number of asthma tweets and the air quality indexes. And so based on this, to cut a long story short, we've found a high level of accuracy, our best, so depending on which class you're talking about, whether it's high, medium, or low. Different techniques work best. So decision tree worked very well for accurately predicting if there were going to be high visits on a day. Neural net, combined with another technique worked very well. A decision tree for medium. And so it's really no one technique that works best. It's a combination of predictive modeling techniques, and we're experimenting with random forest right now and a couple of other techniques as well. So when we showed these results to the doctors, they were actually quite shocked because they thought only medical history would be a good predictor. It turns out, well, you can use these other sources in a very innovative way. These results are very promising. They demonstrate the utility and value of linking big data from diverse sources. And this is the first time, to my knowledge, this is being done for a non-communicable disease. Usually, people have tried to do that for viruses, for the Ebola or for flu, etc. But asthma is a non-communicable disease. It's a chronic disease. And as you saw, it works for asthma. Perhaps it's relevant for other chronic conditions as well, and that's what we want to experiment with. So there are some challenges that we still have to deal with, but first I want to talk about why is this important, why is this useful? Well, this is a population-level risk model. We do want to take it down to the personalized level. So what we think we could do is we can use this as surveillance in real time. And you can also, using these predictions, you can identify patients. In fact, Parkland wants to do this, identify specific patients to whom they can communicate the risk of an asthma attack or the fact that on that particular day, there's predicted high number of people are expected to show up. And it would act as a notification system for individual patients. The hospital is most interested in using our results for making their staffing decisions because, like I said, a lot of times they're overwhelmed with the number of people who show up and they don't expect them, so they don't have the emergency room physicians with the required expertise. They don't have the respiratory equipment that's needed to help these people. And so they're very interested in using this model to use that. And right now, their staffing decisions are being made on a 3-week basis. And so they want to do this so that they can change it on a rolling basis in more real time. We want to be able to do targeted patient interventions using the patient address and geolocation, so alerting them and counseling them on preventive methods using our risk model. But most of all, what we want to do is use other attributes as well. So we haven't really used the individual. So this is not an individual risk model, but we do want to use demographic variables for our prediction. We've also got a buy-in from other major hospitals in the Dallas area when they heard about the results. So now we have access to a very large database that pretty much covers all of the hospitals in the Dallas area. And so the hardest thing to get is the medical emergency records. You can get Twitter data, you can get the Google Trends, you can get the air quality, but it's very hard to extract medical records, and probably either because it's hard to get it out on Epic or a Cerner system, or also because of ownership and privacy issues. So we've resolved those issues. And we've got about 75 member hospitals in the Dallas area that want to work with us. The other thing that we are also doing is we're talking to a startup company that actually uses an inhaler which has an IP address associated with it. And these are inhalers given to individuals, and it actually tracks every time someone takes a sniff from the inhaler. And so we're actually going to get more data on who's actually adhering to their, their prescriptions and actually taking sniffs, et cetera. So hopefully, if we get that data, we can add that. I've already talked about this was data from a single hospital. So we've got more data now. We're also trying to, I'm very interested, I've always followed the stock market prediction models, and so we're looking at those models to see if we can borrow from them and modify them to use an individual level prediction. Another thing that we're doing is, so we did this at a day level, but what happens actually when you look at the data, there's a time lag between them tweeting or between the time that the air quality index changes and them showing up in the emergency room. So we want to bring down, make it more fine-grained in terms of the prediction to an hour perhaps, but what we're also seeing is that in these tweets, there's a distinct pattern that shows escalation of symptoms. So people start by saying, I have some chest tightness, I'm coughing, I was up all night, I've been wheezing, and then the symptoms become more and more severe as hours drag on, as a couple of days drag on, and then you see them saying, I think I'm going to have to go to the emergency room, or I'm on my way to pick up my kid from the school to take them to an emergency room. So we want to use this escalation of symptoms as a way to maybe add some corrections to our predictive model. And last of all, we're building a Twitter-based mobile app to provide patients with real-time information about this kind of risk. So it's been a very interesting experience. We started this project about a year ago, and it was kind of very interesting to work with the emergency room physicians to get their domain knowledge and to use our big data analytics knowledge to put it together. So this is the kind of project we typically like to work on in the Insight Center. And I do want to, again, thank Wenli because she did a lot of the work in actually collecting, cleaning the data, and then doing the analysis. Thank you very much.
Hello. Thanks for the presentation. My name is Sandeepan Bhattacharjee from the School of Pharmacy. So I was just wondering, for a disease state like asthma, so do you think looking into the weather patterns, like seasonal variation is important? And do you think of incorporating that in your data analysis?
Yes, so absolutely. So this pilot project was done over a 3-month time period. Now we've got data for a much longer time period, and we're seeing a lot of seasonal variations that we're incorporating into our predictive model. Another thing that some of you might be thinking about is we've used a subset of air quality data, but temperature changes also trigger asthma attacks, as I understand. And so we're incorporating the temperature information as well. Yes, absolutely.
Thank you. This was very exciting and lots of applications.
I'm sorry,
that
who's
I can
talking?
See.
I can't
Over
see.
here. I'm just wondering, since you've expanded your study and you're now partnering with 75 hospitals in the Dallas area, given the huge percentage of families that are Spanish-only speaking in that area, are you expanding your analysis to also Spanish language Twitter feeds?
So that's an interesting question. We've actually talked about tweets in other languages, and we are seeing a lot of tweets in different kinds of languages coming in that area. So yes, I think we're going to have to expand to these areas. Again, so the tweets themselves, we're going to have to figure out how to actually clean them and how to extract them, because that's going to be a huge input into our, so yes, absolutely. Yes. You know, that's an excellent, excellent question. I would love to get a data set from AT&T or T-Mobile that gives me the text message the actual text and text messages being sent, because I suspect that a lot of people are texting each other, and so I'd love to get that data. So we've actually talked about it in the hospital. Apparently, this hospital, about 80% of the people in this hospital have smartphones, and 90% of them actually use text messages as well as social media. So that is something we would probably have to have an opt-in, because there's huge privacy issues associated with that. But yeah, that would be fantastic. That's another source of data.
Hello? So one of the things I think you did a really good job of is showing the spectrum of symptoms, but there's also a spectrum of triggers. And one thing I wonder if you're missing is that in some cities, there's actually urgent care. So what I'm wondering is, did you track people going to urgent care versus ER visits? Because they've really done that well in many big cities where people don't go to the ER because they have an in-between means of.
You know, that's absolutely right. We've thought about that. So here, this particular data set was only for the ED, but definitely we know that not everybody goes to an ED. And apparently there's also certain zip codes from where people go to an ED and other zip codes where they go to the next day, either to their primary care or to urgent care. So that's part of what we want to do, is to get that data set. So you're absolutely right.
Hi, I have just a real quick question. How did Parkland and U of A get together in this relationship? How did you find each other?
So it's interesting. So I went to give a talk at a symposium for big data, and I was presenting my work where I've done some work on news propagation on Twitter and doing some prediction on how fast a news article spreads and whether you can predict the lifespan of a news article, not a news meme, but a news article. And so the CEO of Parkland Center for Clinical Innovation, Ruben, was in the audience, and he came and said, you know, we want to do something with big data. You know, what can you do to help us? And we got talking about it, and then we said, well, let's work on something together. So it just happened. So it really needs, so I think, John, what you're pointing to is to do something like this, you know, so big data can mean a lot of different things, and if you just start thinking in abstract, it's not easy to come up with a problem. So you really have to sort of think about what are some of the problems, and we tossed around a variety of different ideas, and then we zoomed in on, well, what is a big challenge for you guys, you know? Is it about personalized medicine? Is it something in the ED? Is it treatment for other things? And so we said, well, let's work with the ED. So it also depends on, you know, who wants to work with you. You need the domain experts. You need the data sets. So it kind of all came together, and then we picked asthma. We could have picked some other disease, but we picked asthma because the asthma ED doctors were willing to work with us.
It sounds like you've been getting a lot of momentum and success around the effort. I was wondering if maybe you could speak to how you would potentially operationalize that, or what the hospitals could do proactively to help maybe provide faster care or you know, prevent actual ER visits and suggest other alternatives.
Right, so in this particular case, like I pointed out, I think this is a surveillance system, so we could provide early warning. We could also make the ED better prepared, you know, rather than sort of deciding 3 weeks ahead, you know, how many people of certain types. If we know there's going to be certain numbers during certain days, we could better prepare them and also have the equipment ready in case they show up. Now, prevent asthma, well, you could provide warnings through mobile apps and things like that. So those are, you have to use a multitude of mechanisms, I think, for prevention.
Okay, let's take our last question, then have we get set up for the panel.
Hi, very cool.
Hi, Michael.
Hi. Do you, and well, lots of implications for this, at least in our world, I think we just were talking, very exciting. Do you or Ruben have any insights into other types of chronic diseases that might follow a similar pattern?
So actually, we want to work on diabetes. And for diabetes, I think we can get a lot of data on what people eat through social media and what their work habits are, and wearable devices can tell us a lot about it. So that's the other thing we've talked about, and also about cardiac diseases. So we do want to address other common chronic diseases. So asthma is just an example for us here. Yeah.